Hello, my name is Dr. Nakamura, and today I'll be speaking to you about occlusal equilibration. This is part of your exercise that you're doing on the mounted study casts. So why are you doing this exercise? There is a practical application for this. We start seeing patients. You may need to do some occlusal equilibration if your patient presents with occlusal trauma, if there's some sort of parafunctional habit, or if you want to correct any local irregularities such as extruded teeth, plunging cusps, or if you're planning to do a full mouth reconstruction on a patient, then you would probably need to do some sort of occlusal equilibration in order to help you achieve your goal in treatment. Perhaps Granger put it best when he said that the health of the mouth is related to the function of the mouth. The better the function, the longer natural metabolism can maintain it. So essentially saying that as long as there's good occlusion, good balance, good function, then you can expect the dentition to maintain itself for a long period of time. But most likely, you'll probably be doing a lot of these types of restorations, full mouth reconstructions, crown and bridge work, or even if you're planning to do what we call fixed removable type of reconstructions, where you're doing a fixed partial denture or bridge and combining it with a removable partial denture. You may need to do some occlusal equilibration, or if you're doing a simple implant, right? Implants are very popular now, and if you don't have proper balance of occlusion or a traumatic occlusion on these implants, you may expect to see like implant fractures, porcine fractures, screw fractures. You might even start to see some bone loss occurring around implants due to the occlusal trauma. And if you take a look at this case, here we have a hybrid denture or a high water denture. You could also refer to it as an all-on-4 type of case. Here we have occlusal overload occurring on the denture prosthesis, and this has led to bone loss on the most distal implant, and eventually, failure of the prosthesis. So let's first take a look at some fundamental principles. I'm sure much of this was covered by Dr. Whitaker, so I'm not going to spend a lot of time on it. So a lot of it should be a review. So first, let's take a look at some anatomic considerations. When we take a look at the edentulous maxillary and mandible, what you should notice is that the maxillary arch is narrower than the mandibular arch, and yet what we see is the mandibular dentition is sitting within the maxillary dentition, right? And the reason this happens is when the teeth erupt into the arches, the maxillary arch erupts toward the buccal, which essentially widens the arch, and in the mandible, the teeth erupt lingually, which basically constricts the arch. So even though the actual edentulous form of the arches, even though the maxillary arch may be narrower than the mandibular arch, because of the way the teeth erupt into occlusion, right, the maxillary arch essentially becomes expanded, and the mandibular arch becomes constricted. We also know that when the teeth erupt into occlusion, they could be arranged in one of 3 types of classifications, known as Angles classification. We could have a class 1, class 2, or class 3 type of relationship. And each one of these cases would allow for either effectual or ineffectual incisal guidance in protrusive movements. If we take a look at the class 1, class 2 div 2, we may have sufficient anterior relationship to allow for proper posterior disarticulation and protrusive movements, whereas in the class 2 div 1 and class 3, because we don't have adequate anterior relationships, that we may see more posterior interferences and protrusive movements as the mandible protrudes anteriorly. So let's take a look at mandibular function. First, taking a look at the mandible itself, let's keep in mind that, the mandible is a very unique type of bone in the skull, or actually in the whole body. When we take a look at the joints of the body, either the elbow or arms or knees, we could, when we look at these joints, there's a very distinct left and right side, right? There's a right joint, a right knee, a left knee. Whereas with the mandible, right, it's a single joint with two sides to it, right? It's a single bone with a left and right side. So movement can occur on one side, and movement will also have to occur on the opposite side, right? So it's one joint with two parts. We have to also remember that the condyle, right, sits within the fossa, and as it functions, we have an upper compartment and the lower compartment of this joint in the condyle. The upper compartment is where we have translation, and the lower compartment is where we have rotational movement. And when we combine this with our anterior teeth, it's a combination of condylar guidance and incisal guidance that allows for protrusive movements. So anterior guidance is dependent upon both the condyle and the incisal guidance. And sometimes we could see variations between the angle of the condyle and the angle of the anterior guidance. So condylar inclination, which is pretty much fixed, right, because it's something that we as dentists cannot change, versus the anterior guidance, which we can change either through orthodontics or crown and bridge. There is a relationship between these two. So if we take a look at starting with condylar inclination, we could have, say, if we have an average condylar inclination and average incisal inclination, then we can expect to see the mandible to move evenly with proper posterior disarticulation. However, due to natural variation, we can see, situations where we have a steep condylar inclination, or we could see a shallow condylar inclination. And conversely, we could also see changes in the anterior incisal guidance, right? So we could have average inclination, we could have a steep inclination, such as in the class 2 malocclusion, or we can even have a shallow inclination, right? So as you can see, protrusive movements and anterior guidance is dependent upon both condylar inclination and incisal inclination. Okay? When we talk about lateral movement, we're looking at not only condylar guidance, but we're actually looking at the lingual incline of the cuspids. So for our discussion purposes, we're looking at canine guidance type of lateral movements, right? So it's dictated anteriorly by the degree and angle of vertical overlap of the canines, and posteriorly is dictated by the anatomy and function of the condylar complex, right? So on the working side, as the canines are guiding the movement on the working side, on the non-working side, we could expect to see the posterior cusps disarticulate from each other, and we should see no interferences. Another component to lateral movement is what we call the Bennett shift, or the Bennett movement. So what happens is, if you imagine a axis going through the condyle there, and we expect and we want the patient or the mandible to go to the right side, we could expect rotation of the mandible on the right condyle and translation on the left condyle down the eminence. Okay? But at some point, due to the limits of the ligaments and the musculature, that rotation and translation is limited, and therefore what happens is you see a bodily shift of the mandible to the right side, and that's what we call the Bennett shift. So here we see in this animation, right, we have the mandible moving over to the right, being guided by the canine inclination as well as the condylar inclination. And at some point, like I said, there'll actually be a bodily shift of the mandible to the right side. Yeah. So lateral movement is dictated by the biomechanics of the condyle, that is to say the condyle disc assembly translating along the anterior slope of the glenoid fossa, and the Bennett movement and cuspal inclination. And all these components, the anterior guidance, lateral shift, all that, these are components of the envelope of motion. So if you recall, the envelope of motion looks something like this, right? It's basically an outline of the movement of the mandible, the border movements of the mandible as it goes from centric relation to protrusive to complete opening and back into closure. And everybody functions within this envelope. And the other thing we need to keep in mind is that the mandible also moves laterally, right? So in fact, the Posselt's envelope of motion looks more like this three-dimensional object here, okay? Because we not only do we have the lateral movement, but we also have the sagittal movements. And ultimately, the mandibular function is dependent upon the synergistic relationship of the condyle and dental form, right? So it's this harmony, this synergistic movement of the condyle with the anatomy of the teeth that allows for proper movement and function of the mandible. For our purposes, for the occlusal equilibration exercise, we're going to talk a little bit about centric relation. So if you recall from Posselt's envelope of motion, centric relation is this peak point here on the envelope of motion. It's independent of tooth contact. It's the position clinically identified when the mandible is directed superiorly and anteriorly in the glenoid fossa. It's the position where we only have rotational movement of the mandible, and it's considered the most reliably reproducible position of the mandible. And again, if we take a look at it from a three-dimensional perspective, it's this peak shown here. And of course, it corresponds with the position of the condyle in the fossa, right, in the most superior anterior position where we primarily have rotational movement. So why is this significant? It's significant because it's the most reliable position. We only have rotational movements, and this is the position where you're going to set up most of your denture cases and your full mouth reconstruction cases. It's a position that's irrespective of guidance of the teeth of occlusal surfaces, right? So all patients have centric relation regardless whether they have teeth or not. And just remember that, right, this coincides with your typodont as well as your hinge articulator, right? So remember, your typodont and your hinge articulator just have rotational movement, right? It just opens and closes, which corresponds to the centric relation position. So what is the relationship between centric relation, maximum intercuspation, and centric occlusion? So we talked about centric relation, right? It's an anatomic position of the mandible. It's independent of teeth. Maximum intercuspation, however, is where we have the complete intercuspation of the opposing teeth independent of condylar position. So it's where your teeth meet each other, where they occlude with each other. Centric occlusion, on the other hand, is occlusion of the opposing teeth when the mandible is in centric relation. Okay, but it's important to keep in mind that centric occlusion does not coincide with maximum intercuspation. Okay, so remember, centric relation is purely anatomical. Maximum intercuspation is intercuspation of the teeth independent of condylar position. And centric occlusion is occlusion of the teeth when the mandible is in centric relation and does not coincide with maximum intercuspation. So when we take a look at maximum intercuspation, we know that the supporting cusps, which are the palatal cusp of the maxillary arch, should sit in the central fossa and marginal ridge areas of the mandibular arch. And in the mandibular arch, the supporting cusps are the buccal cusp, and these should sit within the central fossa and marginal ridge areas of the maxillary arch. However, when we talk about having the mandible go into centric relation, right, so essentially what's happening is that the mandible is going to the retruded arc of closure, where the condyles are sitting in the most anterior superior position of the glenoid fossa, where we only have rotational movement. What happens is that we lose our interarch relationships, right? Our supporting cusps no longer coincide with the central fossa or marginal ridge areas of the opposing arch. The other thing to keep in mind is that when the mandible goes into the retruded arc of closure, a narrower part of the mandible is actually sitting in a wider part of the maxilla, right? So when this happens, right, if we take a look at it from this view, right, when the teeth are in maximum intercuspation, right, we see the buccal cusp of the mandibular arch sitting in the central fossa of the maxillary arch, the palatal cusp of the maxillary arch sitting in the central fossa of the mandibular arch. However, when the mandible goes into centric relation, again, right, a narrow part of the mandible is sitting in the wider part of the maxilla. So what happens is the buccal cusp of the mandibular arch may end up hitting against the palatal incline of the maxillary teeth, or we may see the buccal cusp interfering with the palatal cusp of the maxillary arch. So, and when this happens, right, we call these centric interferences, right? Not all the teeth may be touching, so we can't call it maximum intercuspation, right? We can call it centric occlusion, right? But where the teeth are hitting each other are actually called centric interferences. So when we take a look at it from this point of view, right? So here we have the teeth in maximum intercuspation. We let the mandible go into centric relation, right? So when the mandible goes into centric relation, again, we have some occlusal interferences, which we call centric, which we could call centric interferences. We could also call it centric occlusion. We may see an increase in vertical dimension because not all the teeth are occluding at the same time. So we can't call it maximum intercuspation. And because if we do see an increase in vertical dimension, we actually may see a decrease in overbite and an increase in overjet. So the main purpose of occlusal equilibration then is to eliminate these centric interferences so that we can make centric occlusion coincident with maximum intercuspation. All right, so occlusal equilibration. Why are we doing this? Okay. So like I said at the beginning of the presentation, there's some indications of doing it. There may be some areas of occlusal trauma. There may be unstable occlusal contacts. We could have restricted masticatory function. We could have some aesthetic improvements that may be needed. Or it could be to try to treat some advanced periodontitis, or even if the patient has gone through extensive orthodontic care, that we may need to do some occlusal equilibration to even everything out. But most likely, if you wanted to do these type of large restorations, full mouth rehabilitation, it's definitely something that we need to understand how to do. So in vivo, in a patient's mouth, some objectives would be to improve functional mandibular maxillary interrelationships, improve masticatory function, remove any occlusal trigger factors that contribute to bruxism. I'm going to establish a reproducible, stable, simultaneous contact of all teeth in centric occlusion. But the important thing to remember is that because we're removing tooth structure, occlusal equilibration is actually an extremely invasive procedure and should be done first on study models prior to actually doing it in a patient's mouth. So just to review again, right, centric occlusion with the condyle sitting in the most anterior superior position in the glenoid fossa, where we have pure rotational movement. This coincides with our rotational hinge axis, or the hinge that we have on our typodont. And if you notice, if you take a look at your own typodont or at your study cast, you'll notice that not all the teeth are occluding at the same time, right? So you may actually have a centric interference, right? And we call this centric occlusion. And because not all the teeth are in maximum intercuspation, because we don't have all the teeth occluding with each other, we may actually have an increase in vertical dimension. Okay. So again, the objective of the exercise would be to make centric relation coincide with centric occlusion, which then coincides with maximum intercuspation. And keep in mind again that this hinge also corresponds to the hinge in your hinge articulator, which also, is supposed to represent the condyle in centric relation. So in reviewing the exercise itself, it's basically 5 steps. The first step will be preliminary grinding. The second step would be correction of occlusal contacts and centric occlusion. The third step would be correction of protrusive occlusion. The fourth step would be correction of working contacts. And step 5 would be correction of non-working or balancing contacts. So beginning with step 1, the objective is to correct the anatomic relation of a tooth in relation to its adjacent teeth in the occlusal plane within the arch. So basically you're looking at the occlusal plane of each arch to see if there's any teeth that are in either hyperocclusion or sticking out or are not even with the occlusal plane of that specific arch. These adjustments are predominantly anatomic and not really corrective. And what we end up doing is you actually reshape any kind of elevated or tilted teeth. You want to correct the occlusal plane, reshape wear facets, and relieve any type of food impaction sites. So here's my articulator. or not articular, my dentiform that I used. And if you take a look, here we have our centric occlusion, right? You could see that on the left side, not all the teeth are contacting. On the right side, we do have some teeth that are contacting. Okay, so therefore, we do have an increased vertical dimension because of the centric interferences. And if we take a look at, if we use our marking paper, we do see one spot which is a little high. Right here we have a plunger cusp on the palatal cusp of number 3. Right, if we take a look at it from another view, there's our heavy mark, and you can see it right there. So we're going to adjust that mark, okay, until it is the occlusal plane is level. Okay. So step 2 would be corrective grinding and centric occlusion. So the objective is to develop correct tooth contacts and centric occlusion, and to provide maximum harmonious, even distribution of forces, where we have centric relation coinciding with centric occlusion, coinciding with maximum intercuspation. Right. So just as a reminder, the palatal cusp of the maxillary arch are the supporting cusp, the buccal cusp of the mandibular arch are supporting cusp, and we want to make sure that these are the marks that we see. So going over some rules of occlusal adjustment or equilibration. Key points are not to over-reduce cusp height, because this could result in the loss of centric contact and over-reduce the vertical dimension. Whenever possible, we want to maintain centric holding cusps and reduce interferences on non-centric holding cusps. And refine fossa to accept cusp in a stable centric holding position when the cusp interferes in centric only. We want to reposition centric holding cusps by recontouring them, right? We want to recontour them and not reduce them, because when we reduce them, we start to run the risk of closing our vertical dimension, reducing our vertical dimension. Reduce interfering centric cusps only if they are long, grasping, or plunging. Okay. So how do we achieve these types of repositioning? So if we want to move our cusp to the distal, we want to reduce or reshape the mesiocuspal incline. If we want to move our cusp to the mesial, we want to reshape the distal incline. If we want to move our cusp to the lingual, we want to reshape the buccal functional outer aspect. And if we want to move our cusp to the buccal, we want to reshape the lingual incline. Keep in mind that when the mandible goes into the retreator arc closure, when it goes into centric relation, the condyles rotate into centric relation, and the teeth follows an arc of closure, where we tend to see interferences occurring, which can cause the mandible, or will force the mandible to deviate anteriorly, or what we call an anterior slide. So in this case, right, when the mandible goes into centric relation, we might see an interference such as this, and what needs to happen is you just reposition the cusp, and by reducing the distal incline or reshaping the distal incline of the lower premolar, so that way the cusp can sit in the proper, can occlude properly with the maxillary arch. When we take a look at buccal lingual repositioning, like for example, if we have the mandibular buccal cusp interfering with the lingual cuspal incline of the maxillary arch, what we can do is, right, reshape our buccal cusp of the mandible, get it to seat even deeper, but we may start to develop an interference with the palatal cusp against the lower cuspal incline of the lingual cusp. So we reshape the maxillary palatal cusp and allows the mandible to sit further into the maxillary arch or the maxillary tooth, and we are able to reestablish a cusp to fossa relationship in centric occlusion, centric relation, right? So if a centric holding cusp is in hyperocclusion and it is level with the occlusal plane, then the opposing fossa is adjusted. Step 3 is our corrective grinding for protrusive movements. So protrusive movement, remember, relies on the harmonious relationship between posterior cuspal height, incisal inclination, and condylar inclination, right? So if we take a look at, again, reviewing protrusive movements, so if we have our condylar inclination and incisal inclination are parallel, are similar, and our cuspal inclination is similar, then we can expect to have proper disarticulation of the posterior teeth when in protrusive movements. So some rules in corrective grinding for protrusive movements. First rule is in the anterior, we want to reduce the lingual inclines of the maxillary anterior teeth rather than the mandibular anterior teeth, since they are centric holding cusp surfaces. In the posterior, centric holding cusps may be recontoured, not reduced. Okay, we want to recontour them, not reduce them. And if necessary, in the posterior, cuspal inclines and non-supporting cusps may be reduced. Our fourth step would be corrective grinding for working contacts. So the goal would be to eliminate any interferences when the mandible goes into lateral movements. We want to have the movements to be guided by the canines only, so no group function. Posterior buccal interferences are to be eliminated, and possible areas of trauma on the working side are buccal or lingual cusp of maxillary and mandible. All right, so some rules. Rule number 1, working side centric holding cusp must not be reduced and be preserved at all times. And in the presence of working side interferences during canine-guided excursive movements, cuspal inclinations of the opposing dentition may be reduced. So, all right, if we take a look at this case situation here, where we have a interference on the cuspal incline of the maxillary arch, the buccal cuspal incline of the maxillary arch, and the supporting cusp of the mandibular arch, we want to reduce the cuspal incline of the maxillary arch. Or in this type of situation where we have a lingual interference as well as a buccal interference, we want to follow the rule of Bull, which is we're going to reduce the buccal incline of the upper and the lingual incline of the lower in order to eliminate this interference. Step 5 is the corrective guiding for balancing contacts, so the non-working side. If we have any interference of the non-working side, we want to make sure we eliminate that. So the objective is to prevent interferences on the balancing side when the mandible moves into the working side. When the lingual cuspal incline of the upper and the buccal cuspal incline of the lower interfere on the balancing side, adjustment can be done on one of these inclines, not both. Because the upper lingual and the lower buccal are centric supporting cusp, caution must be taken as to not reduce the function in centric occlusion. Again, we want to preserve are supporting cusps, right? And if only one cusp maintains the centric occlusion, it should be preserved. An adjustment is made on the other cusp. However, when there is good centric occlusion, the incline of the upper lingual cusp is reduced. So let's take a look at this diagram. Okay, so we have a non-working interference there. Okay, so what happens is we need to reduce the incline of either the upper or the lower, not both. Okay. So how do you know that when you're done with your occlusal equilibration? You should have equal simultaneous contact between the cusp tips and flat surfaces of all posterior teeth. The mandible is being guided into centriculation, and when force is applied, there's no shift or slide that occurs. There are no posterior working side interferences in lateral canine guided movements. You have no posterior non-working interferences in lateral canine guided movements, and the posterior disarticulation in protrusive movements. Okay, so you should see marks pretty much as you see here on the diagram. Okay, and one good hint or one good tool or way they could use your articulating paper is if you're using let's say the black marks for the maxillary arch and the red marks for the mandibular arch. Okay, when you're going to check your protrusive movements, flip the paper around so that your excursive movements will be marked in red in the upper arch and black in the lower arch, so you won't confuse the marks when you start checking the centric marks versus the protrusive and lateral working marks. So here's a case. This is my typodont that I used. Oh, and this is a really good YouTube video on that would walk you through occlusal equilibration. This is the web address on YouTube. See if you're going to copy that down. So you can see here in my typodont here, I started out with uneven contacts, heavier contacts on the this side, what we call, or the left side, or the patient's right side. Okay, and I went through and started to adjust, do my occlusal equilibration, picking up more marks on the opposing side. Right. Again, getting more marks. So I will tell you this much, that as you go through this exercise, the marks would look worse before they get better. So don't get discouraged. Just follow the rules. Just remember that always preserve the supporting cusps. So that would be the palatal cusp of the maxillary arch and the buccal cusp of the mandibular arch. We want to reshape and not reduce these cusps. And just make sure that in your lateral movements that you're only getting marks in the canines, and in your protrusive movements you're only getting marks in the anterior. We shouldn't see any marks in the posterior region. Okay, again, this is the YouTube video address. And thank you for your attention. Good luck. And if you have any further questions, you could always email me. This is my personal email.